So hi everyone, a very good evening to all of you. Welcome to the 25 important pharmacology clinical question series. So basically we had some issue, that's why we could not come live today, but here I am putting the recorded session for all of you. All you can do is watch this, it will save anyway your time. When I put a question on the screen, you can just read that by pausing and then you can answer and cross verify the explanations eventually. All right. So any questions if you have, you can always contact me on the social media. All right. So anyway, without any further ado, let's get into the session. So here's the first question for all of us. A 32-year-old previously healthy man, after rapidly ascending to 4,500 meters over 48 hours, develops severe headache, vomiting, breathlessness at rest, and even altered sensorium. Physical exam reveals tachypnea, diffuse crackles, and central cyanosis. ABG analysis demonstrates marked hypoxemia with respiratory alkalosis. Which of the following best describes the mechanism of action of the drug used in the treatment? Okay, so giving you time to read the options. Now let's dive into the diagnosis first. I really hope by now you must have made a diagnosis because the height was mentioned in this question. They're talking about this situation called mountain sickness. And doctors, what you must know is if they're talking about mountain sickness, it's an example of a disease which is alkalotic disease. Okay, so if you see, they have mentioned the hint also over here. And what is the hint? They're mentioning that there is alkalosis in the patient. So technically, all we need to do now is to reverse this and produce acidosis to treat this patient. So we need one medication that can produce acidosis. So what is the drug that can do that? I think everybody knows it's called acetazolamide. Acetazolamide. So the way I teach you guys is aceta causes acidosis. Acetoacidosis. So that's the side effect of the drug called acidosis, which we utilize in the treatment of mountain sickness. All right. So now the question is asking, how does that drug acetazolamide works? Okay. So first you must remember, whenever they talk about mountain sickness, if they ask you what is the immediate treatment if the patient is still on the mountain, the best thing to do is descent. If you come down, you're going to feel better. And if they ask you the medicine, then you're supposed to say acetazolamide as the medicine. Now, where does the acetazolamide work? It works in the PCT, right? Proximal convoluted tubule, and it blocks something called carbonic anhydrase enzyme. So basically, this medicine is going to be carbonic anhydrase inhibitor. That's the correct answer for this question. Okay. Now, if you look at the first option, aldosterone blocker is none other than your spironolactone. This is your loop diuretics. Okay, ascending limb is present in the loop of Henle. So this is your loop diuretics. And GABA A receptor, that's somebody else. They're talking things like barbiturates or benzodiazepines. Okay, so anyway, let's revise a thing or two related to this topic over here. This is the first part, that is your PCT, and this is where the drugs called carbonic anhydrase inhibitors like acetazolamide will work. Okay, and even the drugs called osmotic diuretics like mannitol also works here. This is the place number one called PCT. Next, if you talk about the second place, that is the loop of Henle, that is this area. This is where the drugs called loop diuretics will work. Okay, so loops will work here, and another guys that will work here are again osmotic diuretics like mannitol. All right. Next, if you talk part number 3, that is the DCT, distal convoluted tubule. This is where the class of diuretics called thiazides will work. And last and the final, this is the fourth place, that is the collecting duct. And this is where we got the medicines called potassium sparing diuretics. Now, if you pay attention, sparing means saving. You must remember these are the only class of diuretics that actually save potassium. everybody else loses potassium. Are you all with me on that? So only potassium saving, that's why the name is potassium sparing. They save potassium. Rest all the diuretics we talked about, they all will lose potassium. Okay, that is the basic construct that you must all keep in mind. Next, you have this chart for a quick review, and 90% chance there has to be some question on the diuretics coming up from this table. So quickly revising, for example, in the PCT we already mentioned acetazolamide like drugs will work. They are carbonic anhydrase inhibitors. They block one channel called sodium hydrogen exchanger in the PCT. Okay, the most important use where they are used is mountain sickness, which they keep asking in the exam. All right. Next, if we go into the loop diuretics, the most important guy is furosemide, the brand called Lasix. So this guy blocks sodium potassium 2 chloride channel in the loop of Henle. Okay, and you must remember this is the drug of choice for pulmonary edema. Now when it comes to the ions, loops make you lose everything. So this is the mnemonic you have to keep in mind. Loops lose everything. That is sodium, potassium, chloride, calcium, magnesium, everything becomes less in the body. The only difference between them and the thiazides is thiazides also lose pretty much everything, but the only difference is thiazides will save calcium. Are you all getting that? So they will cause hypercalcemia. Thiazides save calcium. Now when you talk about thiazides, thiazides are blocking a channel called sodium chloride symporter. And the most important use of these drugs is hypertension. Although they can be used in some other places, but the most important thing is hypertension. And they're also used for something called nephrogenic diabetes insipidus. Okay. For the central diabetes insipidus, the drug of choice is desmopressin, whereas for the nephrogenic diabetes insipidus, the drug is thiazides. Okay. Next is aldosterone blocker like spironolactone. Spironolactone blocks aldosterone, and because it's blocking aldosterone, sodium will be lost and potassium will be saved. Now, because it's an aldosterone blocker, it should be used when you have too much aldosterone. That's where I want to block aldo. And what is this too much aldo called? Conn's syndrome. Okay. The same drug spironolactone is also the drug of choice in cirrhotic edema, and it's also drug of choice for resistant hypertension. So spironolactone is quite an important drug for the exam point of view. Okay. Next is ENaC blockers. ENaC blockers also come in the potassium sparing only. Okay. So all these drugs are nothing but potassium sparing drugs. Okay. Potassium sparing drugs. Important example is amiloride. So you must remember amiloride is the drug of choice for Liddle syndrome. What is happening in Liddle syndrome? There is too much ENaC activity. Because there is too much ENaC, I want to block ENaC, and that's why I give you ENaC blocker called amiloride. Very important example, Disco is the mnemonic for gynecomastia producing drugs. Spironolactone produces that, but not the cousins like eplerenone, etc. Okay. I also told you, the important drug, the new drug that came in this topic called finrenone. It has some extra properties which we learned, nephroprotective property, antifibrotic property, etc. Make sure you revise that as well. Okay. Next is mannitol. Mannitol is the drug of choice for cerebral edema, the important point of view. Although there are other points that you must go through before exam. So this is a quick recap table that you got for that 1 mark you may get from diuretics. If you're lucky enough, maybe you can get 2 marks also. Okay. So here we are, the next question, doctors. A 58-year-old man with long-standing type 2 diabetes, hypertension, and established atherosclerosis, cardiovascular disease presents with progressively enlarging yellowish plaques over the eyelids. All right. Owing to the recurrent statin-associated myalgias, the physician decides to prescribe an oral lipid-lowering agent that undergoes activation predominantly within the hepatocytes and inhibits the ATP citrate lyase. Which of the following drugs was most likely prescribed in this patient? Okay, so as I'm giving you time to, read the question. Anyway, now that it is done, let's go through this. So they're saying that this patient is having yellowish color plaques around the eyelids. You must know that this is called as xanthelasma. Okay, this is called as xanthelasma, which is actually a sign of excess cholesterol in the body. So that cholesterol is getting deposited. Now, somewhere in the line, they have already given the patient as atherosclerosis, etc. And they've described the patient is on statin therapy. Now, one of the common side effects or important side effects of statin is they cause myopathy or myalgias, okay, muscle pain. So, patient is already on statin and having myalgia. So now what did the doctor do? The doctor has put the patient on the other medicine. Now, just because it's a cholesterol topic, don't choose statin as the medicine all the time, right? Cholesterol topic is again a hot topic for your exam. Something has to come up from this. So that's why we are going to discuss this properly. So statin cannot be the answer for this. Now, this is a question based on the mechanism of action. This drug is a ATP citrate lyase inhibitor. Which drug is this? The answer is bempedoic acid. Okay. Consider this as alternative to the statin type of medicines, right? This is a alternative. Now, as you see this, what is the advantage of bempedoic acid? It doesn't cause that myalgia. That muscle problem which you see with statin will not be there with the bempedoic acid. And how does bempedoic acid work? It blocks one enzyme called ATP citrate lyase. So in biochemistry, if you read the cholesterol synthesis topic, you will see this enzyme. So cholesterol synthesis requires a lot of steps. One of the step in that is HMG-CoA reductase, the rate limiting enzyme. That step in the cholesterol synthesis, it is blocked by somebody called statins. In the same cholesterol production, there's one more enzyme called ATP citrate lyase. Okay, and that enzyme is blocked by somebody called bempedoic acid. So they both work in the same pathway. The only difference is this guy causes side effect called muscle pain, and this will not cause the muscle pain, right? So this is a important drug. Most likely they might end up asking you this. So correct answer here is bempedoic acid. Now, what about the other medicines? Let's have a look at their mechanisms also, doctors. All right. So you must know firstly who is the HMG-CoA reductase inhibitor that they're talking about. They are none other than your drugs called statins. Okay, statins. Next, PCSK9 inhibitor. Okay, so first you must know what is this PCSK9. Okay, so see, in our body there is something called LDL receptors. Okay, when there is more LDL receptors, there will be less LDL because they will consume the LDL. Okay, so more the receptors, the better for us. So what happens is the guy called PCSK9, it will go and it will damage the receptors. It will destroy them. If the receptors are damaged by the PCSK9, obviously we cannot use as much LDL. So what happens? The level of LDL will increase. The level of LDL will increase. That's what is going to happen. So what can I do in this pathway is I can actually block this guy called PCSK9. If I block PCSK9, the LDL receptors will not get destroyed. That means there will be more LDL receptors. When there are more LDL receptors, there will be less LDL. That's how they will work. Okay. So PCSK9 is the enemy, right? That's what you have to remember in the cholesterol topic. So you must destroy the enemy only. So PCSK9 inhibitors are the monoclonal antibodies. Example, the drugs like alirocumab. Okay, alirocumab, and another one called evolocumab. These are the MABs, monoclonal antibodies. And if you notice, they have this letters called OC. Okay, OC in the name. So you can remember, when you do something too much, it's called over. Oye, over mat karo bolte hai na. So that's where OC means over cholesterol. When you're having over cholesterol or excessive cholesterol, then you can use these drugs. Okay, they are the best drugs to reduce LDL. They are the strongest drugs to reduce the LDL. Next, we just now studied somebody called ATP citrate lyase inhibitor, that is called bempedoic acid. Okay, this is bempedoic acid. Next, there is a drug that works in your intestine, in the gut. And what does it do? It stops the absorption of cholesterol. If you're not absorbing enough cholesterol, cholesterol will be less in the body. Okay, it works on something called as Niemann-Pick, protein. So NPC1L1. All right, that's the name of that protein that helps in the cholesterol absorption. So our drug blocks that protein. All right, this is a drug that we had in the option called ezetimibe. Okay, this is that drug simply called by the name of ezetimibe. All right, next is PPAR alpha agonist. You must remember, when you stimulate something called PPAR alpha, it increases one enzyme called lipoprotein lipase, and that will reduce something called triglyceride. This is the best medicine for the triglyceride, and these are the drugs called fibrates. Okay, fibrates. Now this is a new drug, important drug that may come in your exam, siRNA, which stands for small interfering RNA. Okay, small interfering RNA. There's a drug called inclisiran. Okay, I don't know if it's in the option. Yes, I have given that. Inclisiran, this is the name of the drug. Okay, now if you pay attention here, SI means SI, small interfering, that is the word. RNA is kind of jumbled up here. This is the word RNA, 3 letters for you right there. So siRNA drug is having siRNA in the ending, right? That's how you can recognize this drug. So this is called inclisiran. What does this inclisiran do? This is actually a RNA. It's a RNA. What does it do? It interferes and it will reduce the production of PCSK9. Okay, I told you PCSK9 is a villain, right? PCSK9 is a villain. This drug will reduce the production itself. You will not produce enough PCSK9. You will not destroy the LDL receptors. So that's how this will help in the cholesterol topic. All right. Next is this. If you talk about the best medicine to reduce the LDL, best medicines are PCSK9 inhibitors. PCSK9 inhibitors followed by the statins. Statins are also great, but then overall the best drugs for LDL reduction are PCSK9 inhibitors. Next, if you talk about the drugs that will reduce the triglyceride, I just now told you they are called as fibrates, drugs like fenofibrate, etc. Okay, and the medicine that they may ask, which is the best medicine to increase the HDL, the good cholesterol, it is called niacin. You may remember niacin increases nice cholesterol. Nice cholesterol means good cholesterol. Okay, that is a guy called niacin. Clear? So that's about the cholesterol topic. Next is a 41-year-old woman with chronic osteoarthritis have been self-medicating over-the-counter NSAIDs for several months because of persistent joint pain. She now presents with epigastric discomfort, early satiety and melena. The gastroenterologist initiates pharmacotherapy. Which of the following group of drugs is best in this patient? So they're simply saying that patient had some pain. For pain, we take the drugs called NSAIDs, anti-inflammatory drugs. All right. Now, you must remember that if you take NSAIDs, for a while, there is a risk of something called as NSAID-induced ulcer, peptic ulcer, right? So NSAID induced ulcer. So basically the diagnosis is right here, abdominal discomfort is happening, etc., etc. And melena, that is dark stools, probably the ulcer must have ruptured and it's leading to internal bleeding. So that's why probably there is a melena. So we are simply saying that this is a NSAID induced ulcer. And the question is asking which is the best medicine for this patient. Now, please remember, if they ask you the best medicine for ulcer, that is NSAID induced ulcer, your answer should be PPIs, proton pump inhibitors. Okay, that is the prazole kind of drugs. They should be your best choice over here, because the pain that happens in the peptic ulcer is due to the acid only. The peptic ulcer pain happens due to the gastric acid. What you should aim at is to reduce this acid. Okay, that's the logic that we have to follow here. But if they would have given me a word called specific, what is the specific drug that can be given in NSAID induced ulcer, then you can choose the drugs called prostaglandins. Example, misoprostol. Okay. Now, what do you mean by the word specific here? See, how does the NSAID cause ulcer? NSAIDs will reduce something called prostaglandins. Okay, that's the mechanism. By blocking something called as COX enzyme, they reduce prostaglandins in the body. And when there is reduction in the prostaglandin, it leads to ulcer. So if I ask you what is the reason ulcer happens due to NSAIDs, you should say because of reduction in the prostaglandin. So if less prostaglandin causes ulcer, how can you specifically treat that? Increase the prostaglandin. And if you want to increase the prostaglandin, you must give prostaglandin from outside. Example, misoprostol, okay, which is a PGE1, prostaglandin E1, right? So that's about it, sir. Next is a 61-year-old man with a 16-year history of type 2 diabetes mellitus is evaluated during a routine endocrinology visit. He has been receiving the bedtime insulin glargine along with metformin and empagliflozin. His fasting plasma glucose levels are consistently within the target range. However, continuous glucose monitoring demonstrates marked postprandial hyperglycemic excursions. The physician decides to introduce an insulin preparation. Which of the following insulin preparations is most appropriate for this patient? Okay, once again, giving you a few seconds to think through. So, basically, the patient is already on some insulin, but still the postprandial hyperglycemia exists. Okay, so what we have to do is we have to add one more insulin to this, and that insulin has to be the rapidly acting insulin. Rapidly, why do we need that? Because the moment I eat the food, the insulin should be able to fight that, right? It should be able to fight that hyperglycemia. And what is this rapid acting insulin in this? The answer is insulin called glulicine. Okay, insulin called glulicine. Lispro, Aspart, glulicine. These are the insulins that you must keep in mind. Okay, so basically this is the idea that you need to keep in mind when it comes to the insulin. If we put it in the form of a small graph over here, now imagine this is the concentration of insulin or the amount of insulin coming in your blood in this direction, and this is the time on this axis. Okay, so broadly speaking, you're going to have two types of insulins which are important that you must know. One insulin looks like this. It works for around 4 to 5 hours. It works for around 4 to 5 hours. These are rapidly acting insulins. And then there is one more insulin that works for around 24 hours or maybe sometimes more. For example, D-Gludec works much more than that. Okay, so I'm saying there are two types of insulin. One is this short acting insulin that is around 4 to 5 hours, and another is 24 hours insulin. 24 hours means one full day. So usually these insulin should be given once a day as the dosing. Okay. Now people eat their meals, every 4 or 5 hours. That's why these insulins working for 4 to 5 hours, they are also called meal time insulins. That means you should take this insulin, before a meal, because after we eat only the sugar will increase. So we have to take this insulin right before a meal. That's why they have been popularly known as mealtime insulins. So how long before you eat you should take them? The answer is approximately 15 minutes. That means the moment you give this insulin at this point, within 15 minutes, this insulin will be reaching high amounts in your blood. And this is called as peak, right? So because there is so much concentration of insulin in your blood at a moment, what will happen is hypoglycemia. Okay, so these drugs, which are rapid insulins, will have maximum risk of hypoglycemia. All right. And the next thing is, look at the long acting insulins. They're not reaching the peak. That's why known as peakless insulins. Peakless insulins, or they're also called basal insulins. They maintain a basic level of insulin throughout the day in your body, right? So they are called peakless insulins or basal insulins. So that's about it. Now you must keep in mind that these guys don't cause hypoglycemia. No risk of hypoglycemia. Okay. Who is having maximum risk of hypoglycemia? They are the mealtime insulins or rapid insulins. What are the rapid insulins? They are so rapid that they don't have any lag. That's how you must remember. Lag means L for Lispro, A for aspart, and G for glulicine, the one we had over here. Okay. Now, for example, degludec, detemir, these are the insulins which are long-acting insulins. Long-acting insulins. Okay. Like they can work even up till 42 hours. Shortest insulin, if you talk, shortest insulin as of now, it is something called Afrezza, which is a inhalational insulin, inhalational. Okay. And this works for around 2 hours. Okay. This is the one that you have to avoid in people with lung issues like smokers or lung problems, etc. This is the shortest acting insulin. And the longest acting insulins are the ones that you see here. Okay. Example, degludec, detemir, these kind of insulins. Now there is one more that has come. It's called icodec. Icodec works approximately for 1 week, right? There is this new insulin that is soon going to be, launched most likely in India as well. That is called icodec. Okay. Now, as we have talked about that, here's our next question. A 27-year-old male is brought to the ER during summer after developing acute confusion, photophobia, and inability to sweat while clearing the wild vegetations on his farm. On examination, he is febrile, tachycardic, flushed, and markedly dehydrated. Neurological evaluation reveals agitation, mydriasis with sluggish pupillary response, and absent bowel sounds. Which of the following drugs was most likely administered to treat him? So now that we've talked about this, see, this is a case more on the toxicology. If you notice, the dude was working on the farm. The moment farm word comes, many of the people start thinking OP poisoning. Now, this is not OP poisoning because OP poisoning presents with more cholinergic syndrome, meaning you will have more of parasympathetic activity which presents with something called dumbbells. That means patients come with diarrhea, urinary excess, meiosis, bronchoconstriction, etc., etc. But here it's exactly opposite. The patient is tachycardic, okay? The patient is dehydrated, the patient is unable to sweat. These are the things which happens in opposite of parasympathetic, meaning anticholinergic. So the presentation here, clinical features that you're seeing are anticholinergic. Opposite of dumbbells is happening here, tachycardia. Now, when you talk about anticholinergic symptoms, they present with things called belladonna, atropine, or datura. Belladonna, atropine, or datura, these are the three guys that are going to present with anticholinergic features. Okay, so that's what you must know. Now, patient came with something from this. Most likely, it must be datura that the patient might have consumed or been exposed to, or maybe belladonna, something like that. Now, how do you treat anticholinergic? By producing cholinergic activity. And for that, okay, we must give the drug called physostigmine. Physostigmine is a drug that increases parasympathetic activity. It is a drug that comes in acetylcholine esterase blockers. And if you see atropine on the other hand, atropine is a muscarinic blocker. It's a muscarinic blocker, and because of muscarinic blockade, it will reduce parasympathetic. Because it reduces, I wrote it in the anticholinergic atropine. So atropine poisoning में तो atropine नहीं दोगे ना boss. So atropine toxicity, if it happens, or belladonna or datura toxicity, you must give a drug to increase the parasympathetic. And how do you increase parasympathetic? By a drug called physostigmine. Okay. Now this is where you got the different types of poisonings that you can see. So doctors, first is OP poisoning. OP poisoning is due to blockage of this enzyme called acetylcholine esterase in an irreversible fashion. And this blockage leads to excess of parasympathetic. On contrary, datura is going to decrease the parasympathetic. That's why they are opposite. One is meiosis, one is mydriasis. One is bradycardia, one is tachycardia. Secretions increase, secretions decrease, right? So that's why they're working exactly opposite. Okay. Now, in the first situation, parasympathetic activity is too much. So I want to reduce the parasympathetic, for which I must give you a drug called atropine. So what does atropine do? Atropine will block muscarinic receptors and it will reduce parasympathetic. Datura, on the other hand, since already parasympathetic activity is very less, I have to increase it. And to increase this, I am going to give the patient the drug called physostigmine. I just now explained to you how does physostigmine work. It blocks acetylcholine esterase enzyme. Okay. Next, cocaine increases the sympathetic activity. Now, when sympathetic activity increases, it looks almost like reduced parasympathetic. Okay, reduced parasympathetic looks like too much sympathetic. Not every feature, but some features at least. Okay, mydriasis, tachycardia, like that. So you must know, whenever patient comes with mydriasis, either parasympathetic is less. If parasympathetic is less, patients come with opposite of dumbbells. If sympathetic is more, still you will get mydriasis, but there might be other things like more BP, etc., etc. Okay, so this is your cocaine. Cocaine is more like, symptomatic treatment that you have to give. We have to kind of reduce the sympathetic activity, etc., depending on that. Next is opioid poisoning. So what do opioids do? Opioids work on a receptor called mu receptor. Opioids are things like morphine, heroin, etc. So again, here also patient comes with meiosis. So OP and opioid, in both meiosis will come. But opioid is generally a triad. It's a triad of three things. What is the classical triad of opioid poisoning? One thing is meiosis. Okay. Next, you must remember something called respiratory depression. Respiratory depression. And another thing that you must keep in mind is the patient comes in an unconscious state. Okay, unconscious state. So this is what you have to keep in mind. Meiosis, that is pinpoint pupil, respiratory depression, and unconscious state. Meiosis is given fancy name, pinpoint pupil. Okay. So this is where I intend to block the mu receptor. Right now there is too much activity of the mu. So I need to block the mu receptor. The drug which blocks the mu is called naloxone. Okay, this medication is simply given a name called naloxone. IV naloxone is the one that we give in the treatment. Later on, oral naltrexone can be given. Okay, so that's basically it. Next is an 81-year-old retired school teacher is brought by her daughter because of short-term recall and visuospatial dysfunction. While motor examination is unremarkable, MRI of the brain demonstrates diffuse cortical atrophy. The neurologist decides to initiate a monoclonal antibody directed against the aggregated amyloid beta plaques in an attempt to slow down the disease progression. Which of the following drugs is most appropriate for this patient? Okay, so that is what is asked here. Let's go into the question. Doctors, by now you must have figured out by the age and the presentation that they're talking about Alzheimer's disease. Diagnosis of this disease is Alzheimer's. Now in Alzheimer, you must remember the aim of the doctor is we must stop this beta amyloid. If you relate it to your pathology, you all know Alzheimer happens because of deposition of this villain proteins on your brain called amyloid, beta amyloid. They damage your brain. That's why you are seeing cortical atrophy. They damage the cholinergic neurons. Because they damage the cholinergic neurons, acetylcholine levels will go down. So you need to increase the acetylcholine level. If you want to do that, the best drug is called donepezil, which is considered the drug of choice. This drug donepezil increases, acetylcholine. This becomes the drug of choice in the treatment of Alzheimer. But the question did not ask you the drug of choice. They are asking you which medicine can slow down the disease by stopping this beta amyloid deposits on the brain. And that is called adacanumab. Okay, adacanumab, that's the medicine you got to know. Adacanumab, lecanemab, donanemab. These are the drugs that are monoclonal antibodies, the new drugs to stop the beta amyloid. And you can try to remember it like this in case they ask you Alzheimer disease, we use this. So ALD, A for adacanumab, L for lecanemab, and donanemab. Alzheimer disease. Okay. Levodopa carbidopa is used in Parkinson. Selegiline is also used in Parkinson. It's a MAO inhibitor. Okay. Now, as we have discussed this, do read the other things also, like the nootropic drugs in this, like pyracetam, the memory enhancer, that is called nootropic drugs, pyracetam. Memantine is another drug that is a NMDA blocker. Okay, so that winds up the entire Alzheimer topic. A 9-year-old boy is brought to the pediatric neurology clinic because of recurrent episodes characterized by sudden behavioral arrest and blank staring lasting 10 to 15 seconds, occurring multiple times a day for the past year. EEG demonstrates generalized 3 Hz spike and wave discharges. Which of the following agents is most appropriate for the long-term management in this patient? Okay, so doctors, as you see this thing here, you must have figured out by these hints like 3 hertz spike pattern, etc., that they're talking about something called absence seizure. Okay, absence seizure. So in the absence seizure, there are two drugs that are used in general. One is called ethosuximide. Ethosuximide happens to be a calcium channel blocker. It blocks calcium channels in the neuron. Vigabatrin, increases GABA by blocking one enzyme called GABA transaminase. There is an enzyme that breaks down GABA. What is that enzyme? GABA transaminase. So if the enzyme is there, GABA will become less. So this drug will block that. The name itself teaches us that GABA transaminase inhibitor, TR for transaminase inhibitor. Vigabatrin is a drug that is used for another situation in children only. Okay, it is used for infantile spasm, which is popularly known as salam seizure, plus when there is a disease called tuberous sclerosis. Okay, tuberous sclerosis. So when you have tuberous sclerosis plus infantile spasm, we must give vigabatrin. If there is only salam seizure without tuberous sclerosis, then we give ACTH, adrenocorticotropic hormone, ACTH. Okay. Phenobarbital is used in neonatal seizures. Phenytoin is another epilepsy medicine that you know about. So basically the question was asking in absence seizure, which is the most appropriate drug from this topic. It is ethosuximide. Ethosuximide. Now, what is another medicine that is used in absence seizure? It's called valproate. Valproate also is a drug that we use in this situation. Okay, that is in the absence seizure. All right. A point to be remembered, doctor, whenever the question asks you something in epilepsy, like what is the immediate drug that we give or the first drug that is given, that is generally a benzodiazepine like lorazepam. Okay. So when a patient comes to us with any seizure, the first drug that is given during that situation is, IV lorazepam. Later on, after the diagnosis, a proper diagnosis of epilepsy is made, the proper anti-epileptic medicine will be given. All right. Now, next question is 46-year-old woman with metastatic ovarian carcinoma is scheduled to receive a highly emetogenic cisplatin-based chemotherapy regimen. During her previous cycle, she developed severe nausea and repeated vomiting despite standard prophylaxis. The oncologist decides to add an antiemetic agent that exerts its effects by selectively blocking neurokinin 1 receptors, thereby preventing the substance P-mediated emetic signaling. Which of the following drugs acts by this mechanism? So, I hope you have figured out that the diagnosis of this situation is chemo-induced nausea vomiting. Okay, and one of the commonest drugs to cause vomiting, anti-cancer drugs to cause vomiting, it is cisplatin. Cisplatin is that drug that will cause nausea vomiting. That's a chemotherapy drug, chemo-induced nausea vomiting. Okay. So the treatment for this is generally cetrons, 5-HT3 blockers called cetrons. But the question didn't ask you that. Now, if you remember from the classes, you must have learned that there are two types of chemo-induced vomiting, early onset and the late onset. Okay. Early onset means the vomiting that happens within 1 day, that is called early onset, where cetrons are preferred. And the vomiting that happens after 1 day, that is called late onset. So we got early onset and we got the late onset. So right now they're asking the late onset, the drugs called neurokinin inhibitors. Okay, they are called patents. See, what does neurokinin do? Neurokinin basically is working on something called substance P, which causes vomiting. Okay, substance P, there is something in the body that causes vomiting. So, neurokinin, if you block, that is called NK. If you block neurokinin, that substance P will be blocked. And if substance P is blocked, then the vomiting will be blocked. Okay, so these are the drugs called, neurokinin. They are the drugs called petants. You can remember they work on substance P. P for P. PI is P. You read it like that. ANT for antagonist. Antagonist means blockers. P blockers. P. Substance P. Substance P causes vomiting, so they are blocking that substance P indirectly via the pathway called neurokinin pathway. Right? Next is ondansetron. Ondansetron is your favorite drug, 5-HT3 blocker. Right? Scopolamine is used for this thing called motion sickness as a transdermal patch, right? So metoclopramide is one more drug that is also an antiemetic. Clear? So for the motion sickness, which drug do we use? The answer is it's a muscarinic blocker. The muscarinic blocker is called by the name of scopolamine, also known as hyoscine. This is the drug of choice for motion sickness, right? They are the drug of choice for motion sickness. Next, there's another drug that is an antihistaminic. It blocks histamine receptors, H1. So this drug is called promethazine. Promethazine, it can also be used for the motion sickness. And by the way, if you remember the mechanism, the drugs called antihistaminics, the first generation, example promethazine, they also block muscarinic receptor. Their side effect is they block muscarinic receptor. Okay, so you can think by double mechanism, they are actually reducing your vomitings. Morning sickness, again, there is an antihistaminic drug. Okay, this drug is called doxylamine. Doxylamine along with vitamin B6, that is pyridoxine, it becomes the treatment of your morning sickness. Chemo induced, we just now said. Early onset is 5-HT3 blockers. 5-HT3 blockers, they are called cetrons. Late onset, there is neurokinin inhibitors, NK1 inhibitors or substance P inhibitors if you see. They are called petants, just now we saw. Okay. Lastly, antiemetic drug causing EPS, extrapyramidal side effects, example Parkinson. Meaning if you take this drug, you will get Parkinson-like symptoms. That drug is called metoclopramide. Metoclopramide. So what is this drug metoclopramide? You must know it blocks dopamine. It's a D2 blocker and it crosses blood-brain barrier and blocks it. Sir, what is this drug? You take this drug. It crosses blood-brain barrier and it reduces dopamine. If you reduce dopamine in the brain, that's called Parkinson. And you get much more effects. They are all combined called as EPS, extrapyramidal side effects. So muscular dystonia, Parkinson, all this kind of things are produced by one antiemetic drug called metoclopramide. Do you remember there's something called drug-induced Parkinson? It's not normal, it is drug-induced. That Parkinson happens due to drugs. Which drugs? Example, metoclopramide. Okay. So here you go. Next question. A 68-year-old man with a long-standing history of poorly controlled hypertension presents with progressive urinary hesitancy, weak urinary stream, nocturia, and a sensation of incomplete bladder emptying for the past several months. The physician decides to initiate the pharmacotherapy. Which of the following drugs is most appropriate for this patient? All right. So now, based on the presentation the age, the presentation, etc., you must have figured out by now that this is a case of BPH. All right, this is a case of BPH. And many of you remember there are two drugs very popular for the BPH. One is tamsulosin, another called sildosin. Sir, sildosin is not the correct answer here. You must be wondering why. That's the most popular drug we all have heard about, tamsulosin and sildosin, alpha 1A blockers. Alpha 1A. Alpha 1A, they can only treat BPH. Okay. Next, if you pay attention in the question, the patient also has hypertension. That means I need to treat hypertension plus BPH. And that's where the guy called prazosin comes into play. Prazosin is a alpha 1 blocker, not alpha 1A. It works on alpha 1A also, alpha 1B also. So this drug will be useful in those patients having BPH plus hypertension. Okay, BPH plus hypertension, prazosin must be given. Okay, so PR for pressure, PR for prostate. That's how you have to remember. Prazosin is for double effect. So prazosin, terazosin, these are the drugs that I should go for. So correct answer is prazosin, because this patient has both hypertension and BPH to be, corrected. How about finasteride, dutasteride? These both drugs, they are 5-alpha reductase inhibitors. Okay, these both are 5-alpha reductase inhibitors. Now, when you give something called 5-alpha reductase inhibitor type of a drug, this will reduce the size of the prostate. Okay, actually speaking, in the treatment, we have to give two different drugs. One for symptomatic relief, we have to give drugs like tamsulosin or prazosin, depending on the patient has hypertension or not. That is for symptomatic relief, tamsulosin, sildosin or prazosin. But to reduce the size of prostate, because it's a hyperplasia, we need to reduce the size of prostate, we have to give something called finasteride. Okay, that becomes your combination treatment. All right. Next, a 34-year-old woman with a long-standing history of bronchial asthma develops acute wheezing, nasal congestion, and dyspnea shortly after taking aspirin for dysmenorrhea. Physical exam reveals bilateral expiratory wheeze and multiple nasal polyps. The pulmonologist decides to prescribe a drug that takes care of this patient's symptom. Okay, so what is this? The diagnosis, as usual, for everything we are just making first, it is aspirin induced asthma. Aspirin is which type of a drug? NSAID, right? So why does it happen? You must know there is something called arachidonic acid. I'll talk about this. By the way, hoping you guys remember, there is something called Samter's triad. Okay, something known as Samter's triad. So what happens in Samter's triad? You have nasal polyps, you have, these asthma and the aspirin sensitivity. That's what is happening here. So let's remember it more like Samter's triad, I always tell. NAS, if you read it like that, you will be reminding yourself of nasal polyps. And AS word you have to remember for asthma associated with aspirin. Okay, asthma associated with the aspirin. Okay, so why does it happen? Now let's try to understand. There is this pathway called arachidonic acid pathway. Arachidonic acid pathway divides into two things, as you know. One called as COX pathway, another called as LOX pathway. COX and the LOX pathway, correct? So now what happens, check this out. The COX makes something called prostaglandins and the LOX make something called leukotrienes, which will cause bronchoconstriction. Okay. Now, this pathway will split into two. But when you give drugs like aspirin or NSAIDs, they block this. NSAIDs will block this pathway. Okay. Example, aspirin I'm writing here. When you give aspirin, aspirin will block this pathway. So, forcibly, the arachidonic acid will now shift towards which side? Towards the leukotriene, and it will cause asthma. Bronchoconstriction will happen and this will cause asthma. So, which pathway is causing asthma? The leukotriene pathway. So, there, how can you treat this? You should try to block this also. If you block this, bronchoconstriction will not happen. Yes or no? Aspirin is forcing the LOX pathway to happen, but you can block it at this leukotriene step. Yes or no? So, what is this drug that can do that here, sir? The answer is Lucast. Okay, this drug called Lucast here, Montelukast or Zafirlukast. This is the drug that we can give here. Ipratropium, it's used more for COPD. Omalizumab is used for allergic asthma because it blocks IgE. IgE is responsible for allergy, so that's why it's used for allergic asthma. Theophylline is also a bronchodilator, by the way. It is the only oral bronchodilator. Rest all of them are taken by inhalational route, but this one is a oral bronchodilator. Fine. Next, doctors, a 23-year-old medical student is brought to the emergency department 10 hours after ingesting a large quantity of tablets in a suicide attempt. He complains of nausea, repeated vomiting, and right upper quadrant abdominal pain. Lab investigations reveal markedly elevated serum transaminases and prolonged prothrombin time. The treating physician explains that the hepatic injury results from the depletion of glutathione stores, followed by the accumulation of a highly reactive toxic metabolite generated by the cytochrome P450 enzymes. Which of the following toxic metabolites is primarily responsible for this patient's hepatocellular necrosis? Okay. So guys, suicide attempt by medicine. One of the common medicines that people attempt suicide with is paracetamol. How do I know this is paracetamol? They have given right upper quadrant pain. That means something related to liver. Okay. They have given some enzymes. All right. And if you can notice hepatic injury, you all should know by the back of your hand by now that PCM causes liver damage, right? Now, many of you are accustomed to knowing the antidote called N-acetylcysteine. N-acetylcysteine, that is the antidote. Okay. So, what does it do, N-acetylcysteine? Basically, why is the liver getting damaged? There is this bad guy called NAPQI. The one in the bracket I'm writing is actually called NAPQI. NAPQI. Okay, this is called NAPQI. This is the guy that damages your liver. And the N-acetylcysteine will block that. Are you all getting that? N-acetylcysteine will block NAPQI. And what happens when the NAPQI gets blocked? The glutathione, which is a good guy, will keep increasing. What does the villain do? This is the bad guy, sir. Who's the bad guy? NAPQI. NAPQI will reduce glutathione. Glutathione is an antioxidant. It is a good guy who will go down now. So, what are we doing? We are damaging the villain by giving an antidote called N-acetylcysteine. So, basically, that's something you have to keep in mind. Okay. You must know that when somebody ingests paracetamol, first day the liver enzymes will start to increase and eventually by day 2-3 they will be damaged to the liver. Next in this, you'll be able to see the different antidotes. Okay. If they ask you what is the antidote for, let's say, this OPs or carbamates, OPs or the carbamates, then we have to say the drug of choice for this is called atropine. And why exactly am I giving atropine here? Because OPs, carbamates, they increase parasympathetic. So many times I've told you this now. And atropine will reduce parasympathetic by blocking muscarinic receptors. Next, belladonna, atropine, datura, they are the guys that reduce parasympathetic. So the aim in the treatment, it is to increase it back by giving physostigmine. Physostigmine increases parasympathetic back again. Beta blocker toxicity, beta blockers will reduce something called cyclic AMP, second messenger. We need to increase the second messenger back again by giving glucagon. Glucagon increases cyclic AMP. Digoxin, one of the drugs from arrhythmia topics. Okay, you have to keep in mind to remove it. There is a drug called digibind. Digibind is a antibody. It's an antibody fragment. Okay, nice name, digibind. It binds to digoxin. Paracetamol, just now we studied. What does paracetamol do? Paracetamol will increase somebody called NAPQI, which will reduce glutathione, and we increase the, we reduce the NAPQI, and eventually the glutathione will keep increasing. Aspirin or barbiturate, meaning they are acidic drugs. They are acidic drugs. Whenever an acidic drug doesn't have an antidote, how do we remove that drug is? Make it uncomfortable by making the body opposite. What is that? Make the body alkaline. Acidic drugs are removed by alkaline diuresis. Okay, and this is done by giving bicarbonate to the patient. Bicarbonate is a alkali. Benzodiazepine has an antidote called flumazenil. Flumazenil. Benzmefulmaze. Benzmefulmaze. Right? You have to remember it like that. Opioids, we learned opioids, there is mu stimulation. Then we give naloxone, which blocks the mu stimulation. Alcohol, there is a drug called fomepizole we have to give. Fomepizole. Fomepizole blocks one enzyme called alcohol dehydrogenase. Okay, basically this is what we treat. Methanol poisoning we have to treat. Methanol poisoning. Okay, curare drugs. Curare drugs, if you remember, there is an antidote called neostigmine. There are many curare drugs. The treatment given is neostigmine. Especially for rocuronium and vecuronium, if they ask, a new antidote is there only for these two drugs, rocuronium and vecuronium. It's called Sugamadex. Okay, Sugamadex. So this becomes quite an important table for all of us. This includes the antidotes. Next is a 65-year-old man with a history of anterior wall MI, long-standing hypertension, and ischemic cardiomyopathy, presents with progressive exertional dyspnea, orthopnea, bilateral pedal edema, and reduced exercise tolerance. Echocardiography demonstrates a left ventricular ejection fraction of 32% with global hypokinesia. Lab investigations reveal elevated BNP levels. The cardiologist explains that while several medications may improve the symptoms, not all of them have been shown to confer a survival benefit with long-term use. Which of the following drugs does not reduce mortality in this patient? All that long story cut short, by now you must have figured out by multiple hints given in the question that this is a case of heart failure. So diagnosis of this is heart failure, CHF. Okay, so I am simply asking you which drug does not reduce the mortality, right? Does not reduce. So doctors, be careful with the words like except, not, etc. on the day of exam. Okay. Why? Because despite knowing, if you lose out a question, that is painful. If you didn't know it and yes, you lost the question, it's all right. And there will be a decent amount of questions that we always tell you during classes also that you will not know. Our game is to pass the exams via the questions we know. Okay. Whatever has been taught to you by any faculty anywhere, doesn't matter. They will teach you a substantial amount of information that comes in the exam. Okay. Only the language of the question may change. The reason of me giving you all this big type of questions, even in my previous sessions, my questions look like this only, because your exam trend has changed and many of you got the taste of it in the last session. Okay. So big questions came. They were like, sir, by the time we scrolled down reading a question, we forgot what's happening above. Only to make you practice that kind of a situation, again, you can see in this series. Not only in this, previously also you can go and check. Okay. So practice this. These are like the highest yield things that I've chosen for you guys. Okay. Don't just watch this exact video. If you have time, remaining month, one video you can watch in like 2-3 days, right? So you will get to understand the case scenarios quickly. Buzzwords. Okay, I see this in the question. You will know this is what they're talking about. So to catch that kind of things, you have to read these things at least twice, thrice. Watch this at 2x speed at least 2-3 times. And trust me, 1 to 2 days before exam, you got to watch this, right? Because even though you're watching right now, you may forget these buzzwords, the way we are catching the scenarios. Okay. 1 minute is all you get over there. In that 1 minute, you have to read this big of question and still pick the correct option. Okay. So people who have practiced this, every time I tell you guys to watch these videos at least 2-3 times, not just this, even the previous ones, most of the previous exam questions, they didn't feel like, it was big, etc. At least when it comes to pharmacology, I'm talking about. They said like, we had practiced this kind of scenarios right here, example. So that's what is our motto. Watch this before the exam and go. Watch it now once and again repeat that. So that way you end up memorizing even the buzzwords and everything. Okay. So anyway, coming back to the question, now you might see the question is saying that which drug does not reduce the mortality, although it's used in heart failure. Sir, acute heart failure, the drugs which we use like dobutamine, milrinone, etc., they stabilize you temporarily, but they do not reduce the mortality. Okay, milrinone or dobutamine. These are the two drugs which we use in the acute CHF and they don't reduce mortality, sir. But the other drugs in this option, they reduce the workload. Okay, they reduce the workload. The ones who reduce the workload, they are the ones who will reduce mortality. Simple logic is, if something is failing, if you use it little less, it can survive longer. A tire which has a puncture, if you are doing triple riding on that, one though you will get a challan from the police, another thing the tire will burst, right? But if there is a puncture, meaning the failure has started, if you get off the bike, neither the police guy will catch you nor the tire will puncture. So reducing the workload can make it survive longer, sir. So all the other drugs in this topic, they reduce preload, afterload. That's why they are reducing mortality, except for the drugs we use in acute heart failure temporarily, that is dobutamine or, milrinone. All right. So dobutamine stimulates beta 1 receptor and it increases something called inotropy. So these drugs are called inotropes. Inotropes means they increase the force of contraction of the heart. Okay. Next, You know this mnemonic I teach you guys? Super cool, bhai sahab. That means this is a cool thing that these drugs, they reduce mortality, that you have to keep in mind. And from this, you must remember, if you combine something called sacubitril plus a drug called valsartan, this fixed combination is given a title called ARNI. Now, what is ARNI? Angiotensin receptor drug called sartans. Angiotensin receptor blockers are called sartans. And N for neprilysin inhibitor. Neprilysin inhibitor is called sacubitril. So it's a combination of two drugs, angiotensin receptor plus neprilysin inhibitor drug. Okay, that is called ARNI. Gliflozin, very important drugs repeated in the exam again and again. This is actually a drug from the diabetes topic, SGLT2 inhibitors. Okay. So these are the drugs when you take glucose flows in urine. You can see the name gliflozin, glucose flows in urine. Okay. Next, some beta blockers which are important here. So basically they are the ones, they cause decrease in the cardiac mortality. We are talking about the drugs. What do? They decrease the cardiac mortality. Okay. So basically there is a drop in the cardiac mortality by these drugs. Okay, big cardiac mortality drop. Cardiac mortality means bisoprolol, carvedilol, and metoprolol. Okay, carvedilol is a special drug. C for calcium, A for alpha blocker. It has extra properties now. Carvedilol is a calcium plus alpha blocker. To an extent, it also has something called antioxidant effect also. Okay. Next, doctor. So we got a 49-year-old man presenting to the emergency department with excruciating pain involving the first metatarsophalangeal joint that began abruptly overnight. He reports similar self-limited episodes over the last 2 years, usually after heavy alcohol consumption and large meat-rich meals. His medical history is significant for hypertension and a stage 2 CKD. The selected drug acts by non-competitively inhibiting xanthine oxidase. Which of the following was most likely prescribed? Okay, so you must be able to recognize they're talking something related to joints. There is pain, joint pain called, gouty arthritis. So this is a case of gout. How else do I know that? Gout happens when you consume a lot of foods that can increase uric acid. Example, purine-rich foods like red meat, etc. Alcohol can also increase your uric acid, by the way. So, if you take too much uric acid, at least you should be able to remove it. But now this guy can't even remove it because he's having CKD. So, people with long-term CKD, they can't remove the things from the body. So uric acid also is one thing that will increase in them. All right. So this is a thing. And what do? We give a xanthine oxidase inhibitor. What do xanthine oxidase enzymes do? There is something called purines. So when purines break down, they break down into uric acid. And too much uric acid is called gout. And the enzyme that is doing this is called xanthine oxidase. So when you give medicines called xanthine oxidase inhibitors, uric acid levels will also reduce. So what are those drugs which are in this list, which are xanthine oxidase inhibitors? There is one drug called febuxostat. XO means xanthine oxidase, or allopurinol. Or febuxostat, they are the xanthine oxidase inhibitors. They are the most preferred drugs in the long-term management of gout patients. Okay. So febuxostat or allopurinol, preferably allopurinol. If patients have allopurinol allergy, I may go for febuxostat. Okay. Now, these two drugs are used in acute gout. Acute gout. Colchicine and indomethacin. All right. What do you do in acute gout? You want to reduce inflammation. You want to reduce inflammation so that the pain will reduce. And how can you do that? One by drug, which is a NSAID. The most preferred NSAID in this topic is indomethacin, or colchicine, which stops the migration of neutrophils. It inhibits the migration of neutrophils. If you block the neutrophils, the inflammation will not happen again. All right, that's the logic that is straightforward here. So just now we learned this acute gout mein what do we give, sir? We give medicines like one called indomethacin. Indomethacin, that is the drug of choice, and we may also give colchicine. Chronic xanthine oxidase inhibitors like allopurinol or febuxostat. Uricosuric means these are the drugs that will increase the excretion of uric acid. Xanthine oxidase means they will reduce the production of uric acid. Uricosuric mein there is one important example called probenecid. This drug, when you take, what happens? There will be more excretion of uric acid. But there is an issue. If you excrete too much uric acid, it will lead to stones. Next is uricase analogs. Uricase analogs. Uricase, look at the name. If lipase can break lipids, uricase will break uric acid. So this will cause breakdown of uric acid. Okay. So it will break down the uric acid into a substance called allantoin. Allantoin. It happens by something called oxidation reaction. And the drug that can do that is called rasburicase. Nice name. It has uricase in the name itself. So uricase drug will break down uric acid. Especially this drug is used in the treatment of tumor lysis syndrome, which can cause hyperuricemia. Okay, so this is about the topic called gout. A 36-year-old woman presents with recurrent unilateral pulsatile headaches associated with nausea. She also has a past medical history significant for stable ischemic heart disease and exertional angina. Which of the following drugs is contraindicated in this patient? All right. So the diagnosis of this case will be migraine. Okay, unilateral pulsatile headache, nausea, etc. So you must know when it comes to migraine, which drugs do we use in the acute attack, which one do we use in the chronic attack, etc. So let's go and talk about this. So once I am an established diagnosed patient of migraine, meaning the doctor told me I have migraine, I have to take a medicine if I get migraine very frequently. So every day I have to take a medicine, whether today I have migraine or I don't, I have to take this medication. That's called prophylaxis. And the drug of choice for that is called propranolol. That is the drug of choice. But you must know that beta blockers are contraindicated in ischemic heart disease. Okay, contraindicated in ischemic heart diseases, beta blockers. So then in that situation, I may go for other drugs. There are many others, but most likely it may be a drug like topiramate. So for prevention also, you must remember two drugs, not just the drug of choice like propranolol. Propranolol, of course, it's used, but then if you have a history of IHD, then I might go for a drug like topiramate. Next, if you come to me with headache right now, okay, you come to me, you're my patient, you're saying, sir, it's paining right now. Then to reduce your pain right now, I may choose something called NSAIDs. Okay, drugs like naproxen, ibuprofen, etc. Those drugs can be chosen. Those are the NSAIDs. And for the severe, we go for the drugs called triptans. Triptans are, the drugs called 5-HT1B agonist. Okay. When you have a bad headache, B for bad headache, triptans are used. Okay. But triptans, they cause vasoconstriction in the heart as well. So basically, they are contraindicated in IHD. So both the drug of choices, if you notice, they are contraindicated in the ischemic heart disease patients. So in the ischemic heart disease, the treatment will be a drug called lasmiditan. I used to teach you less MI. Less MI, the name itself is telling us that less MI drug is, this lasmiditan, ischemic heart disease, example MI. So if you have MI plus migraine, see what the question is asking. If they're asking prevention, don't give propranolol, give something else. If they're asking treatment, then give lasmiditan. Okay. So what was the question asking us? The question is asking which drug should be avoided in this patient. So avoided mein kaun se honge sir? As we said, propranolol. Propranolol should be avoided in this patient. I may go for something else. Okay. By the way, ergots are those that will cause ergotism like features. They will cause vasospasm in your fingers, giving you gangrene like effects. You may remember ergots, Rott's fingers. That's how we learn it. So nitroprusside should be given for the treatment for that, gangrene. A 29-year-old prima gravida at 10 weeks of gestation undergoes open reduction and internal fixation following a major lower limb fracture sustained in a RTA. 2 weeks later, she develops sudden onset pleuritic chest pain, dyspnea, hemoptysis, and painful swelling of the left calf. Which of the following drugs is most appropriate in this patient? Okay, so now this looks like a case of DVT which has converted to pulmonary embolism. Okay, so fat embolism or whatever it is, basically this is a case of pulmonary embolism right now. As we are seeing that after the RTA, etc., she might have been immobile, and if she was not moving, probably it led to a DVT, and eventually what has happened is she got a pulmonary embolism. And all in all, pregnancy is considered to be a hypercoagulable state, meaning already pregnancy predisposes you to clotting. On top of that, she was not moving because of the accident. That means she might have gotten all that. So in this situation, what am I supposed to give? The most appropriate treatment is giving heparins. Okay, we got to give something known as heparins in this case. Okay, now as we all see this thing here, let's talk further. Okay, if we look into the discussion of this DVT, pulmonary embolism type of topic, what you and I must know is what drug to be given. Okay, first trimester, that is up till 12 weeks, I'm going to give you a medicine called as heparins. Okay, so 12 weeks or so, I'm going to give you again the drugs called heparins. mostly low molecular weight heparins. Okay. Next is second and the third trimester, that is 12 to 36 weeks. Again, I can give you low molecular weight heparins, that is the preferred medicine. That is the preferred medicines. Warfarin can be given only in the second and the third trimester because warfarin is teratogenic. We can't give it in the first trimester. Okay. First method, there is no way I can give you warfarin. Warfarin can only be given after the organs have already formed, etc. So, second and third trimester, I can give you warfarin. Okay. That too, generally, heparins are preferred over the warfarin here also in the second and third trimester. And there is a clause in that warfarin can only be given if the dose requirement is less than 5 mg per day. Okay, then only I can continue warfarin in this patient. Otherwise, I'll have to anyway give heparin. But anyway, if you have to choose between the two, heparins are a better choice. At 36 weeks, again you have to switch to heparins only. Okay, again you have to switch to heparins. Why are we doing that? Why not continue with the warfarin after that to basically reduce, to avoid warfarin induced intracranial bleeding? To reduce the warfarin induced intracranial bleeding, meaning if you continue the warfarin, the baby may have intracranial bleeding. So that's where you must switch to heparin. Usually the one that we prefer is unfractioned heparin, UFH. Even in the upper cases, we wrote low molecular weight, although we can use unfractioned heparin there also. Okay, that's about it. So overall, what is the drug of choice? If you notice, if you forget low molecular weight or UFH, etc., heparin. Heparin is the preferred medicine in the pregnancy when it comes to this anticoagulant topic. Okay. So I hope that is clear to everyone. So anyway, the answer for this is low molecular weight heparin, doctors. A 35-year-old woman presents with progressively worsening fatigable muscle weakness that becomes more severe towards the evening and improves after rest. She reports difficulty swallowing. Lab testing demonstrates antibody against the postsynaptic acetylcholine receptors, and the CT imaging reveals an anterior mediastinal mass suggestive of thymoma. The patient is started on a standard long-term pharmacotherapy for symptomatic improvement. Which of the following best describes the pharmacological action of the drug used in this patient? All right. So based on the things that have been given here, it's a classical case of myasthenia gravis. Why? Because the muscle seems to be relaxed. That is what is happening. That's why there is muscle weakness given in the second line. Okay, that becomes more severe towards the evening and improves after rest. Okay. Thymoma is a strong association pathology with myasthenia gravis that you can't forget. Okay. So what is the question asking in the end is, which of the best describes the pharmacological action of the drug used in this patient? Okay, first of all, what is the drug that we prefer in this treatment? See, what is the aim of the treatment here? We are increasing the acetylcholine for more muscle contraction. Okay, so let's talk about this. Because of muscle relaxation, the patient comes to us like this, which is called as ptosis. Drooping eyelid called as ptosis. Eyelid is relaxed like this. But when you give a medicine that can contract the muscles, you know that the patient is getting better. The eyelid has opened, meaning the patient got better. And for this, we do this diagnostic test, which is given a name called tensilon test. Okay, it's given a name called tensilon test, and the drug to be used here is called edrophonium. Okay, edrophonium, it's a short-acting drug that we use in the diagnosis of myasthenia gravis. Now, please don't confuse. There are many other tests that you must have learned in your internal medicine, ISPAC test, EMG, etc., etc. So I'm not talking this is the best test or anything like that. I am just saying one of the tests from myasthenia topic is tensilon test. Okay. Now, next is what is the treatment? Obviously, edrophonium is a short-acting drug used as a tester during diagnosis. Treatment has to be a long-acting drug. And for the treatment, what do we end up giving is a drug called pyridostigmine, which is the longest acting drug in this topic. Or there's an intermediate acting drug called neostigmine. Intermediate meaning it's not that long. Stigmines is the name of the class here. This is given for the treatment of the disease called myasthenia. But when you give these drugs, there will be some side effects, cholinergic side effects that will come. To reduce those cholinergic side effects, we give atropine. Atropine is a muscarinic blocker. Why are we giving this? To reduce the side effect of the pyridostigmine or neostigmine. Okay, so that's all about this. So going back now, pyridostigmine or neostigmine, etc., all these drugs, how do they work? The stigmine drugs, we have learned it before, they block one enzyme called acetylcholine esterase. Okay, that's the correct answer. Muscarinic agonist drugs. Muscarinic agonist drugs means they are drugs like pilocarpine, bethanacol, etc. Muscarinic antagonist means the drugs that generally have trope in the name, atropine like drugs. They are the ones in this. Okay. So some of you will argue atropine also you wrote in the treatment. That's not the treatment. Atropine is only given to reduce the side effect, of stigmates. That's not the treatment. Okay. A 54-year-old obese man with a 10-year history of type 2 diabetes mellitus is evaluated during a routine outpatient visit. He is currently receiving metformin therapy. However, because of his previous MI and mildly reduced ejection fraction, the physician decides to add an anti-diabetic drug. During the follow-up, the patient is counseled regarding the important adverse effects associated with this medication. Which of the following adverse effects is most commonly associated with the drug used in this patient? All right. So, first of all, you have to figure out that the patient is already on some medication. They added a word that patient's ejection fraction is less, meaning he is having heart failure. Remember a while ago we mentioned that a diabetes drug is used in heart failure. What is that drug? It's called gliflozins. So now the question is saying that when you add gliflozin, what side effect should you expect? Gliflozin causes glucose flows in urine effect. So when glucose flows in your the urine, obviously you're going to have what? Genital infections and urinary tract infections. So this is what is going to happen with the drugs called gliflozins. Okay, this will happen with the gliflozin. Hypoglycemia will happen due to the class of drugs called sulfonylureas, example glimepiride, etc. Lactic acidosis is due to metformin. Okay, marked fluid retention, etc. can happen due to glitazones. Okay, pioglitazone, etc. They can do that. So basically that's about this. Very important drug, gliflozins, their side effects, etc. You must keep in mind. Once again, as a recap, we can do that. Just now I told you hypoglycemia, it is by the drugs called sulfonylureas, meglitinides, and remember the insulin, rapid insulins can also do that. Rapid insulin. Next, weight loss is happening by couple of drugs, but most important that you can't forget, because they are primarily used for the weight loss right now, it is that drug called semaglutide. Is the GLP-1 agonist. There are other drugs also that causes weight loss in the diabetes topic. I am just giving one example to you as of now. Please refer to the main notes and learn from that. Semaglutide is that drug I'm writing. Okay, very important. Lactic acidosis, we already said metformin can do that. Because of this, it's contraindicated in renal failure patient. Risk of lactic acidosis especially increases if you have renal failure. Flatulence, diarrhea, etc. That is by the drugs called, alpha glucosidase inhibitors. Example, acarbose, absence of carbs. So when you take this medicine called alpha glucosidase inhibitors, when you eat something, what will happen now? That glucose will not get absorbed. And if glucose does not get absorbed, what is going to happen is it will be in your GIT, and in the GIT, it will end up causing, that flatulence and diarrhea. Okay. Next is UTI, genital infections, etc. This we just now mentioned. This is by gliflozins. Okay. Next is a 26-year-old man is brought to the emergency department after being stung multiple times by the bees while working outdoors. Within minutes, he develops the generalized urticaria, swelling of the lips and tongue, severe wheezing and dizziness. On exam, his blood pressure is 76/44 mm of mercury, pulse rate is 132, and the oxygen sat is around 88%. The emergency physician immediately administers the drug of choice for this life-threatening situation, which is the most appropriate treatment from this list. Okay, so you must have figured out that this is the diagnosis of anaphylactic shock. And what do we give in anaphylactic shock? Adrenaline. Okay, but how do you give adrenaline? That is important. 1:1000, that is the concentration of adrenaline, and that is given by IM root on the thigh. Okay, IM root on the thigh. And if this is not working, then you go for IV adrenaline, but you have to dilute and give. That is 1:10,000 concentration. Okay, so you must remember, when you talk about adrenaline in the anaphylactic shock, IM is better than subcutaneous. Cardiac arrest, IV is better than intraosseous. And there is something called vasomotor reversal of Dale. What is happening in vasomotor reversal of Dale? If you give adrenaline plus alpha blockers, example phentolamine, phenoxybenzamine, something like that, it will lead to profuse hypotension. due to beta 2 receptor. You know that adrenaline works on beta 2 receptor. To prove that adrenaline works on beta 2 receptor, the scientists called Dale did one experiment. Now, right before exam, we don't have as much time to discuss every detail right now. Just keep in mind, when you give alpha blockers, this will happen. Adrenaline plus alpha blocker, if you give, the patient undergoes severe hypotension due to beta 2 receptor, because the beta 2 receptor, what does it do? It causes vasodilation, and that will cause hypotension. Okay. Next is a 17-year-old boy brought to the endocrinology clinic because of excessive thirst and passage of large volume of dilute urine for the past 4 months. His mother reports that he wakes up multiple times at the night to drink water and has recently developed fatigue and the weight loss. 2 months earlier, he sustained a traumatic head injury in a road traffic accident. Lab investigations reveal serum hypernatremia, increased plasma osmolality, and markedly low urine osmolality. A water deprivation test fails to concentrate the urine. Which of the following is the most appropriate for long-term treatment of this patient? Okay. So if you check out the clinical features that has been given in this, disease, what is happening here? First of all, the diagnosis. It is diabetes insipidus. Diabetes insipidus. You must remember diabetes insipidus is of two types, central meaning brain and nephrogenic, that is kidney related. So doctors, they've given an RTA head injury type of a history. That means something happened to the brain probably, and that's where the patient has developed diabetes. So I'm assuming this is central diabetes insipidus. Okay. So what happens in diabetes insipidus? Now, if you're talking central, there is absence of ADH, also called as vasopressin. Now look, ADH, what does ADH do? ADH saves water. The name itself is saying anti-diuretic hormone. It saves water. So if you don't have ADH, if there is absence of ADH, you can't save water. You will actually lose water. Okay, you will lose water. So doctors, that's why they're saying that there is low urine osmolarity. That means concentration in the urine has reduced because there is too much water in the urine. Okay, so this is clearly telling me it's a case of diabetes insipidus where there is no ADH or vasopressin. If I don't have vasopressin, let's give vasopressin from outside. Only the name will change. That is called desmopressin. So desmopressin, it is the drug of choice for central diabetes insipidus. It works on V2 receptors. It's a V2 agonist. It will work and save water for you. And the same desmopressin is also used, okay, in nocturnal enuresis. Nocturnal enuresis. But I'm sure you know from different subjects that for the nocturnal enuresis patient, the best thing to do is called bed alarms, right? The best treatment for this patient will be bed alarms. And you must keep in mind that if they ask you a drug that is supposed to be given, then desmopressin is the drug of choice. So desmopressin is drug of choice for two things. One is central DI and the second is nocturnal enuresis. 42-year-old man with multiple drug-resistant pulmonary TB is initiated on the newer BPAM regimen after failing the conventional antitubercular therapy. During a teaching round, a medical student asks about the pharmacological action of the P component of the regimen. What is that? That means, okay, first you guys try solving that. All right. So in the B palm, the question is asking, how does the drug P works in the B palm? What is the drug P? P for pretomanid. Okay. Let's look at the different drugs here. DNA topoisomerase inhibitors or gyrase inhibitors, they are the drugs called as floxacins. In the B palm, the M stands for moxifloxacin. So that's how it works. Okay. Next, ATP synthase inhibitor. It is a drug called bedaquiline. So bedaquiline is a ATP synthase inhibitor. Okay. So you must remember this drug inhibits ATP synthase. All right. That is the B component in the B palm. Next 50S inhibitor is called linezolid. It inhibits the protein synthesis. Okay. Protein synthesis inhibitor. This is a drug called linezolid. That is the L. And mycolic acid inhibitors. It is the drug like delamanid and pretomanid. You can try to remember it as MA, mycolic acid inhibitors. IN word hai, IN for inhibitors. Delamanid and pretomanid, they are the mycolic acid inhibitors. Okay. So floxacin, bedaquiline, linezolid and pretomanid, these are the drugs. So they asked what is the drug P mechanism here. So P for pretomanid, it's a mycolic acid inhibitor. Where is that option, sir? It has to be option B. Okay, it has to be the option B. All right. So that's all about this. TB ka jo, there is other details also, please revise that. For example, if a patient is diagnosed with HIV and TB together, which treatment is given first and why, you know, that iris syndrome, etc., that we talked about, you should revise that. Okay. Next question is, a 34-year-old man presents to the emergency department with nausea, flushing, throbbing headache, palpitations, and dizziness shortly after consuming a drink at a social gathering. He reports that he had recently been prescribed antimicrobial therapy for amoebic dysentery. Which of the following drug is least likely to produce this reaction? Okay. So first of all, if you notice the patient is having certain symptoms after drinking, that means it is something called disulfiram-like reaction. Okay. So the diagnosis in this will be disulfiram-like reaction. All right. So doctors, there is a mnemonic, at least you must remember, most common cause. Let's think of it like that. Most common cause: metronidazole, antibiotic; cefoperazone, cephalosporin, again an antibiotic; chlorpropamide, diabetes drug, and there are some antifungals also. Like, the list goes on, but minimum you must remember this, especially metronidazole. They have asked this previously as well. So the least likely drug to do this is amoxicillin. Okay, amoxicillin. So what is the story? Let's talk. So doctors, when you look at the ethanol metabolism, whenever you drink alcohol, that is ethanol, what ends up happening is this ethanol, doctors, will convert to something called acetaldehyde. This acetaldehyde will convert to acetate and it will go out. Okay. So when you give a drug called disulfiram, it blocks this enzyme called acetaldehyde dehydrogenase. So which drug blocks this? Disulfiram. And when this enzyme is blocked, now what ends up happening? The levels of acetaldehyde will increase. The levels of acetaldehyde will increase. But when will they increase? Only if you drink alcohol. Otherwise, they will not. If you drink alcohol, alcohol cannot move further because there is a blockage. So who will increase now? The levels of, acetaldehyde. And this acetaldehyde makes you sick. And which drug is going to make you sick? Disulfiram. Disulfiram. This is the drug that makes you sick. So all I'm saying to you right now is this, that disulfiram was the drug made so that people quit drinking. But some other drugs do the exact same thing, meaning they also make you sick if you drink alcohol with those drugs. And those drugs copying disulfiram are called disulfiram-like reaction. That is by the drugs given in the list: metronidazole, cefoperazone, chlorpropamide, etc., etc. Okay. Next question. A 32-year-old man with major depressive disorder started on pharmacotherapy after presenting with persistent low mood, anhedonias, hypersomnia, fatigue, and reduced concentration. 2 weeks later, he attends a party. Shortly afterwards, he develops severe occipital headache, palpitation, diaphoresis, and marked hypertension with a blood pressure of so and so. Which of the following drug was most likely prescribed to the patient? Okay, so low mood, anhedonia, etc. Doesn't this sound like depression? Okay, so this person must be a depressed patient. So, depressed patient, he took something, that is, he attends a party mein, obviously he must have drank alcohol. So, do you have the relation in your head now? Party, that is alcohol, plus depression. Hoping you have connected the dots and you diagnose this is cheese reaction. If you consume alcohol or things like cheese along with MAO inhibitor drugs, you will get cheese reaction. Diagnosis is cheese reaction. And the drug that can do that is, example, phenelzine. And there are other examples of MAO inhibitors that you can check in the notes. Okay. So I am simply saying that what is cheese reaction? Why does it happen? Let's try to understand the logic, sir. Okay. There are certain foods, when we consume them, they contain something called tyramine. Tyramine is present in foods like wine, cheese, etc. So, if tyramine increases in the body, it makes you release more noradrenaline, and noradrenaline will increase BP. In simple language, if there is more tyramine, there is more of BP. More tyramine, more BP. So every time we drink wine or eat cheese, why isn't our BP increasing? Because there is a protector. Who is this protector? One enzyme called as MAO. MAO will break down tyramine. So if there is no tyramine, there is no BP. So in our GIT, who is present, who is preventing all this? An enzyme called as MAO. So MAO is the good guy preventing this high blood pressure. But on contrary, in depression, we take drugs called MAO inhibitors. Yes or no? We take MAO inhibitors in depression. So MAO inhibitors, if you're taking, now if you drink wine or eat cheese, what will happen? Tyramine will accumulate, and that will increase the noradrenaline, and that will increase BP. This is called cheese reaction. And how do you treat this cheese reaction if they ask you? The answer is phentolamine. Okay, phentolamine. Phentolamine is actually a alpha blocker, reversible alpha blocker, non-selective reversible alpha blocker, right? So that's all about this, sir. Okay. So that's why we chose the answer as phenelzine. Phenelzine is nothing but a MAO inhibitor type of drug. So MAO inhibitor plus tyramine leads to cheese reaction. A 34-year-old man with multiple endocrine neoplasia type 2 presents with recurrent episodes of pounding headache, diaphoresis, palpitations, and severe episodic hypertension. 24-hour urinary catecholamine antimetabolites are markedly elevated. Before the surgical management, the patient is started on a drug. Which of the following drugs was most likely prescribed to this patient? Okay, Hoping you have made a diagnosis by now that this is a case of pheochromocytoma. Okay, pheochromocytoma, that's the case that we are talking about. And the drug that you must give for this, it's called phenoxybenzamine. Okay, phenoxybenzamine. Now, when it comes to pheochromocytoma, by the way, make sure you're reading these questions well because they contains the buzzwords. This may help you with internal medicine also later because the words like, catecholamine, multiple endocrine neoplasia, that is men, right? Or the headache, palpitation. These are all the things you have to learn from internal medicine. Metanephrine levels needs to be checked, right? So remaining questions also, pay attention to the question stems, please. They will help you even with your clinical subjects. So when you talk about pheochromocytoma, you must remember this, sir. Pre-op, that means before the surgery, I need to control the BP. I'm going to use a very long-acting drug called phenoxybenzamine. Long name also. So phenoxybenzamine is given. Intra-op means during the surgery, BP shoots up. I'm going to give you IV drug called phentolamine. Okay, phentolamine. And pre or post-op, both times you can use these drugs. They are drugs like nicardipine or labetalol. You all know nicardipine and labetalol, anyway, they are used these days in hypertensive emergencies. Whenever your BP shoots are very high, we can use nicardipine, labetalol. So pre or post, anytime you can use these drugs. Okay, drugs like nicardipine or labetalol. Next, a 29-year-old woman presents with multiple hypopigmented anesthetic skin patches and thickened peripheral nerves. She started on a multiple drug therapy. 3 months later, despite the strict adherence to the combined OCPs, she is found to be pregnant. Which of the following was the most likely responsible for the drug failure in this patient? So multiple hypopigmented anesthetic patches means she was having leprosy. Now, if you talk about leprosy, the treatment that is given in leprosy is called DRC, dapsone, rifampicin, and clofazimine. Dapsone, rifampicin, and clofazimine, those are the drugs given there. And from the drugs, rifampicin is the one that would have caused the OCP failure. Now, this is a very classical case. I have told you multiple times during the classes also. You must remember this rifampicin and OCP story. Anyway, what is the concept behind this? Let's try to understand. Okay. So guys, you must remember that inside our human body, there are some enzymes which help in removing the drugs. Okay, there are some enzymes helping us in removing the drugs. If this enzyme increases, that is called induction. And obviously, if this enzyme reduces, that is called inhibition. So what happens due to this? More enzymes to remove the drug. More enzymes means more drug will go out of the body easily. And this will not allow the drug to stay back in the body. And this will lead to what? Failure. It will lead to failure. Yes, are you understanding? If there is more enzymes to remove the drugs, drugs will go out quickly and it will lead to failure of the drugs. And if you cannot remove the drugs from the body, that means enzymes are very less in the body. You can't remove the drug. The drug will stay back in the body and this will cause toxicity. Okay. So now you must understand who increases them, who decreases them. There is some mnemonics. For example, we saw rifampicin case. Okay, we saw rifampicin case. So if you give some other drugs with rifampicin, there is a chance that they may fail. If you give some other drugs, what will happen? There is a chance that they may fail. So what should you do as a doctor in the compensation? If the drug is failing, as a compensation, what we can do as a doctor is increase the dose of failing drug, increase the dose of failing drug. Okay, increase the dose of failing drug. And if the drug is becoming toxic for you, reduce the dose of toxic drug. Simple logic. Okay, if the drug is failing, take more of that. And if the drug is becoming toxic for you, take less of that. Simple logic. Arrows dekh lo bhai. If there is an inducer, you are supposed to increase the dose as a doctor. If there is an inhibitor, you are supposed to reduce the dose. Reduce the dose. Okay. Rifampicin, if you use it with anybody, it will cause failure of that. You may also remember one more example I might have told you. Rifampicin can cause the failure of one HIV drug called dolutegravir. So that's why we double the dose of dolutegravir. DDD याद रखना होता है, double the dose of dolutegravir. Rifampicin will fail, dolutegravir. Okay. So as I told you, what do you do to dolutegravir because it's failing? Double the dose. That's what I told you. Increase the dose of the failing drugs. Okay. So you have to remember which drugs can fail the others and which drugs can actually cause the toxicity of others. Mnemonics are there. You have to memorize this. Okay. This concept also they love to ask in your exam. Enzyme inhibitors and enzyme inducers. Okay. A 24-year-old prima gravida at 18 weeks of gestation presents with intermittent fever associated with chills, rigors, headache, and malaise after returning from India. Peripheral blood smears demonstrates enlarged erythrocytes containing trophozoites and the Schaffner dots. The obstetrician initiates appropriate therapy but avoids one particular drug because of its potential to cause oxidative hemolysis in the fetus. Which of the following drugs should not be used in this patient? Now, ladies and gentlemen, I don't know how much you figured out in this or not, but one thing you must know, it's a malaria case. At least based on the drugs you can figure out it's a malaria case. Schaffner dots you see in Plasmodium vivax. So it's a malaria from somebody called vivax. Okay. So how do you treat vivax? We'll learn this here. Check this out. First of all, if you look at the guy that is vivax, the drug of choice mainly for the treatment is called chloroquine. Okay, chloroquine. Chloroquine is given for 3 days in the treatment. That's written as CQ. CQ is chloroquine. So chloroquine is a nice drug. It can be used in normal people also as well as pregnant people. So either ways, same drug is used for Vivax, whether you're normal or whether it's pregnancy. But one drug is missing here. Which drug is missing? Primaquine. Primaquine cannot be given in pregnancy. It's contraindicated in pregnancy. Okay. So that is clear. Next, for falciparum, what is the treatment? Falciparum, the treatment is called ACT. ACT is the treatment again for 3 days only. But in pregnancy, the story is like this. First trimester, you should give quinine plus clindamycin for 7 days. Meaning, if you're diagnosed with malaria in the first trimester of pregnancy, you have to give a 7-day treatment and you're done. What drugs? Quinine plus clindamycin. First trimester, you're treated like a queen. Okay. Second and third trimester, you can go back to the drugs like ACT for 3 days. Meaning the same thing you can give in the second and third trimester, but not in the first trimester. Okay. So that's about this. Anyway, the mnemonic I teach, hoping you guys remember. Very cool fact. Very means Vivax, cool means chloroquine. F for falciparum, ACT is ACT. artemisinin combo therapy. Okay. And in the severe cases of FALSI, we must give IV artesunate. IV artesunate. Okay, that is given in the severe cases. So the question was asking which drug should not be given in pregnancy. The answer is nothing but your primaquine. Okay, primaquine. And this thing is called AL. AL treatment means artemether plus lumefantrine. This is the treatment of FALSI in northeastern states of India. Northeastern states of India. That is basically ACT. ACT means combination therapy. And the rest of India, we give ASP. Okay. Artesunate plus sulfadoxine plus pyrimethamine. That is what is called ASP. Okay. Although we said 25. Let's have a bonus question. A 28-year-old man with schizophrenia has been receiving antipsychotic therapy for the last 6 months. Recently, he developed resting tremors, rigidity, and bradykinesia, for which an additional medication was prescribed. 2 weeks later, he complains of dry mouth, constipation, blurred vision, and palpitation. Physical exam reveals tachycardia and decreased bowel sounds. Which of the following is most likely responsible for this adverse effects? Schizophrenia. How do you treat schizophrenia? Antipsychotic drugs. Already given in the history, antipsychotic drug was given. Okay. Now, what is happening? Patient, after giving antipsychotic therapy, developed some symptoms. That is Parkinson-like symptoms. What is the Parkinson called this time? Drug-induced Parkinson. Antipsychotic drugs like haloperidol, etc., they will cause drug-induced Parkinson. Now, to treat the drug-induced Parkinson, some drug must have been given. And when you give that drug, some side effects happen. Now, look at the story. Patient was given some antipsychotic. Example, I'm assuming it may be haloperidol. What did the patient develop? Patient developed drug-induced Parkinson. Now the drug-induced Parkinson is treated by something like Benz drugs, Parcure Benz drugs. If I ask you the drug-induced Parkinsonism, the treatment called benztropine, benzhexol, also called trihexyphenidyl, how do they work? They block muscarinic receptor. Features will be opposite of dumbbells. Opposite of dumbbells. Muscarinic block. Side effects will be decreased parasympathetic functions. Opposite of dumbbells means dry mouth. Mydriasis. Mydriasis will lead to blurred vision. Constipation. Palpitation due to tachycardia. Right? So basically this is a patient who was being treated by benzhexol. Sir, these symptoms are not happening due to haloperidol. Haloperidol से drug-induced Parkinson हुआ. You got drug-induced Parkinson. And how did you treat the drug-induced Parkinson? By a drug called benzhexol. Now the benzhexol is causing all the side effects. So how does the benzhexol work? It's a muscarinic blocker. Okay. Muscarinic blocker. Dopamine agonists are the drugs like bromocriptine or cabergoline, which are used in hyperprolactinemia. Dopamine blockers are the drugs, antipsychotic drugs. Because they block dopamine, they can cause Parkinson-like side effects called EPS. Ryanodine receptor blocker is a drug called dantrolene. Dantrolene is used for a situation called malignant hyperthermia or neuroleptic malignant syndrome. Okay, so you can all have a look at this. EPS, extrapyramidal side effects. First, you must remember, if you talk about EPS, it will always be by typicals more than atypicals. typical antipsychotics have more chances of causing Parkinson-like syndrome compared to atypical. Example, haloperidol. Haloperidol has more chances compared to atypicals like risperidone, etc. Okay. Next, you will get the symptoms and you have to treat those symptoms. For example, this is treated by Benz drugs. Parkinson is also treated by the Benz drugs. Akathisia will be generally treated by the beta blockers. Nervousness. Revise this topic from the psychiatry also. Tardive dyskinesia. Tardive dyskinesia is something else. So this is known as rabbit syndrome. The patient gets this perioral movements looking like a rabbit. That is called rabbit syndrome. This is treated by drugs like valbenazine. Neuroleptic malignant syndrome is actually muscle contractions causing hypothermia. It's a life-threatening hypothermia. And this is what is treated by the drug called dantrolene. Dantrolene, ryanodine receptor blocker. Weight gain is mostly by the drugs called clozapine or olanzapine. Clozapine or olanzapine, they causes weight gain. And hyperprolactinemia, it is most commonly by the drugs like risperidone. How do you treat hyperprolactinemia? If they ask you, we need to stimulate dopamine, because if you stimulate dopamine, prolactin levels will reduce. Okay, dopamine stimulation will reduce prolactin. That's the relation. Dopamine and prolactin are opposite. And these drugs are called bromocriptine and cabergoline. Cabergoline and bromocriptine. Okay, these are the two drugs. And one more aspect we can add to this, it will be weight loss. Weight loss is by two drugs, or weight neutral to be precise, not weight loss. Weight neutral drugs will be aripiprazole, and ziprasidone. Aripiprazole and ziprasidone, these are the drugs that are weight neutral. They don't cause as much weight gain. They don't cause as much weight gain. कैसे याद रखेंगे? If you walk from point A to point Z, if you're walking so much, you will not gain weight. But if you take Ola for a very close distance also, that means you're not walking every time you take a cab, you will gain weight. If you take Ola for close distance, you will gain weight. And if you walk from A to Z, you will not gain weight. That's just an easy way to remember this. Super high yield chart, every time there has to be a question coming from this. Okay. So that's about it, my friends. Hoping that this session helps you to assimilate all the information that you have learned in pharmacology. Definitely, if God is with us, you're going to see questions coming from this session itself in your exam. You know, quite a decent amount of question, especially if they're going to ask a neutral exam. There has to be a decent amount of questions from this. Make sure, again, reminding you to watch this. Okay. My best wishes and prayers are with all of you, and I hope that you guys do the exam well. Okay. And if you have any queries, etc., please feel free to text me. The moment I get to see your text, eventually I will definitely respond. That's my Instagram. Like the ID is Dr. Salk. In case if you don't want to type that, you can just scan the QR. Most likely this also can help you join the page. Okay, so waiting for your comments. How did you feel this session was? Please give us that boost also. We also work hard to give you this kind of sessions so that it's a booster for your preparation. At least give us a thumbs up and some love in the comments that yes, it helped you revise this content and it will help us going as well. So hoping for the mutual symbiosis. God bless you all. Take care, everyone. Waiting for that one message from you after exam that you passed. Okay, as always. Good luck.